Bismillahirrahmanirrahim. My name is Dr. Murtaza Shafqat. I'm an endocrinologist practicing in Pakistan Kidney and Liver Institute Hospital, Lahore, and Hamid Latif Hospital. And these are my disclosures. So today we are going to talk about, as the month of Ramadan is approaching, we are going to talk about the role of Rhizodeg, which is a combination of degludec and aspart in Ramadan. I would try to keep this presentation more practical because lots of clinicians are here and they want to listen to the practical things. Please forgive me if there are some busy slides, but I will try to keep it as simple. So the learning objectives today is to talk about the role of education in Ramadan, the risk stratification and diabetes management in Ramadan, and the concept of co-formulation, which is available and which we are going to talk about today is the Rhizodeg, which is a combination of degludec and aspart. And insulin adjustments during the Ramadan, quite a common question we see every day and asked by the patients and clinicians as well. Right. So where are we now in diabetes management in Ramadan? Let's talk about some statistics. Diabetes impact on the world and Pakistan. As we all know, that the prevalence of diabetes is significantly increasing. You see, in 2021, we have 537 million people. And by 2045, it is expected to approach to 783 million, and it's the worldwide data. So it's not only Pakistan. But if you talk about West, USA, United Kingdom, Europe, it's increasing globally, which is, of course, very alarming. Where we stand in Pakistan, it is the third country where we have 33 million people, unfortunately, living with the diabetes. And I must say that almost half of them are still undiagnosed who don't know that they have diabetes. If you talk about prevalence, then unfortunately, Pakistan stands number one. The burden of disease has increased more than 70%. So what has gone wrong post-COVID? As we are talking about Ramadan, so I would touch upon these stats that we have around 1.8 billion Muslims worldwide, 150 million Muslims with diabetes worldwide, participate in fasting, and almost 86% type 2 diabetic patients fast during Ramadan, at least for 15 days. Now, this is a bit of pathophysiology of fasting in patients with diabetes. The issue is that in fasting, it's not just the hypoglycemia, but the risk of hyperglycemia is equally high. The risk of ketoacidosis or ketosis is equally high. So it's not just hypoglycemia that we are worried about as a clinician. We are also worried about our patients having severe hyperglycemia or ketoacidosis. What are the challenges? So the challenges, as we are discussing, that there are hyperglycemia is a challenge, of course. If the patient is on dual or triple insulin therapy a day, still you can have a hyperglycemic episode or coma. Hypoglycemia is another challenge. Variability, I will show you a slide just in the next few minutes where we will see that the variability of glucose is actually very high in fast or Ramadan. Compliance is an issue, of course. In Ramadan, so I want to, you guys have a look at this slide. This is a very important slide. You see what happens in normal day before Ramadan, there are less peaks and troughs. We don't like peaks and troughs in diabetes. We want a stable glucose levels, and that's our aim. So you can see that before Ramadan, there's a bit of peak, but it's not as bad as in Ramadan. Because in Ramadan, you can see dips and peaks. So it's not just the risk of hyperglycemia or hypoglycemia, it's the change in the variability of the glucose as well, which is an independent risk factor for the microvascular and macrovascular complications, along with risk of patients going into the coma. And you can see around iftar time, the blood sugar goes low, and when you open the iftar, obviously there's a peak with it. Optimizing glycemic control while securing patient safety is a key challenge, especially in a country like Pakistan, where, of course, being a clinician, it is our duty to educate the patient, not only educate the patient, but also the clinicians. As we were discussing earlier, these are the two major problems that we see in a patient who is fasting: hypoglycemia and hyperglycemia. Now, the data suggests, the research suggests that during Ramadan, the hypoglycemia risk is almost doubled. So if someone is having 1 or 2 episodes of hypoglycemia a day on multiple dosage of insulin, it will almost double in Ramadan. I always tell my patients, and we have seen it over a period of years, and my clinicians, the senior clinicians will also agree with this, that the most scary thing that a diabetic patient can have is an episode of hypoglycemia. Because, you see, it affects multiple organs of the body. Some people just collapsed. If they are elderly, frail patient, they are at home, they can collapse and there's nobody to look after, they can go into permanent coma. So it can lead to even death. So the risk of hypoglycemia is not a joke. It can take your life. Not just the brain. It increases the risk of myocarditis because, of course, the stress hormones, the catecholamines, the glucagon, everything goes high. So the risk of MI and cardiac arrhythmias is almost doubled. And falls, especially this is a problem in the elderly or frail patients, where they keep on falling and, the risk of hypoglycemia, this fall can cause their life. Driving accidents. If you're driving, you're diabetic, you're fasting, you're having an insulin, and if your blood sugars drop, it will not cost only your life, but other people's life as well. So we were just discussing about the hypoglycemia. Hyperglycemia is another challenge. It's not just the hypoglycemia, it's the hyperglycemia as well. And the data suggests that in Ramadan, the risk of hypoglycemia increases almost 5 times. It is a significant increase in the risk. Now, we have put this slide because you see, the problem in the Ramadan is that you're fasting, you're open, especially at this Sahri time or at the Iftar time. There's a risk of post-meal hyperglycemia. Of course, you try to eat, and in Pakistan, we have a trend to take more and more carbs, actually, unfortunately. So the post-meal hyperglycemia is an independent risk factor, not for microvascular, but microvascular and vascular events as well. Role of education in Ramadan. So, of course, as a clinician, it is our duty to educate our patients, not just in Ramadan, but weeks before Ramadan. We should start preparing weeks before our patient. If a patient is, because the patient may not come to you in Ramadan and may not get a chance to ask a question. So it is our duty to assess a month or 2 months before Ramadan, anyone coming to your clinic, to assess whether he is fit for Ramadan or not, and we'll go in detail what are the points to look at. Well, we all know a diabetic patient always walk on the tightrope, especially if you are on multiple daily insulin injections or multiple drugs. There's always a balance you have to maintain between a hyperglycemia and hypoglycemia. And, you don't want to fall off from the rope. And this is quite challenging at times. An approach. How would you approach a patient of type 2 diabetes during fasting, as I was mentioning earlier? That we should be preparing in advance, not just in the month of Ramadan. Actually, a few weeks before, we should be preparing our patients. And what are the things to, talk about, and what are the things to look at? So, pre-education Ramadan, what education you are going to give to your patient about Ramadan? So, you should mention about blood glucose monitoring, the importance of blood glucose monitoring, when to check, when to act. You should advise about the fluids and dietary advice. You should talk about exercise as well. These are the minimum points you should touch when you're talking to a patient with diabetes and the Ramadan is coming. You should talk about what medications you are on, what insulin you are on. Do you check your blood glucose? What sort of fluid intake you have? What sort of diet you have? what sort of exercise you do. And we should also tell patients about these numbers. Numbers are very important. Lots of patients who turn up in my clinic, they don't know actually. They say, oh, my blood sugar is 120 and I'm having hypoglycemia. 120 is not a hypoglycemia. Maybe the patient may experience hypoglycemia on 120 because the blood sugars were very high and now they are suddenly going in the normal range. But we should tell the numbers as well. The numbers have their own importance. So we should tell that if the blood glucose is less than 70, of course it is hypoglycemia. Not just hypoglycemia, but the hyperglycemia as well. Most of the patients end up in our clinic having a blood sugars of 400 going on for months. So in Ramadan, we should focus on these numbers, that these are your numbers. And of course, we should talk about period of illness, dehydration, because most of the patients have the comorbidities with diabetes. They have renal disease, they have a heart disease. So it's not just the diabetes you are dealing with. As a diabetologist, as an endocrinologist, you have to have a holistic approach. You need to see what sort of medication patient is taking for heart failure. What about the kidney? It's not just the numbers you're looking at and you're making adjustments. You have to take a holistic approach. A typical Pakistani, we are all familiar with this sort of meal. And of course, I can bet that most of us will be having this at our at least iftar. This is a meal with a high carb intake and it is not good for diabetic patient. What should be the Ramadan plate like? I mean, we want a plate like this. We want a plate which contains a mixture of carbohydrate, proteins and fat, not just carbs. Of course, it is a difficult task to tell this thing to the patient, but this should be the minimum standard. Post-Ramadan follow-up. So when the Ramadan is gone, it's not the end. Why the post-Ramadan follow-up is important? Because you need to make the post-Ramadan assessment. So there is a pre-Ramadan assessment and there's a post-Ramadan assessment. And we'll talk about, what sort of things you are going to look at the post-Ramadan assessment. One of course, you have to adjust the insulin dosages. You might have omitted certain tablets that you may have to introduce again. If the patient has been able to have a safe fast 1 year, he may not be able to do it next year. So don't assume that, doctor, I had this, I was managed to have fast for last being 15 years. Yes, you were, but the time has changed. Your diabetes has changed. Your complications has changed. So as we all know that diabetes is the most difficult disease to treat. I always tell my patients because it changes with everyday activities, what you eat, what you drink, what you exercise. So again, post-Ramadan follow-up is also very important. As per our holy book, Quran, Surah Al-Baqarah, 183, 185, and the teachings of Hazrat Muhammad Mustafa sallallahu alaihi wasallam, there's a clearly exemption from the fasting, and we should tell this patient, we should tell this, that this is in our religion, this is in our Islam, that if you are ill, if you are child, if you're pregnant, women who are breastfeeding or during their menses, any person traveling, you are exempted from fast. So we should tell these things to the patient that it's in the Quran. This is a real world study in Pakistan, and actually I looked at this study when I was looking at the slides of this presentation, and it shocked me as well. Look, so what they find out that less than 15% of Pakistanis who experienced symptoms of hypoglycemia during Ramadan broke their fast, which means that 85% of the people, they noticed that their blood sugars are going low, but because of religious things, they kept on continuing with the fast. And they were not aware that they're not doing good to themselves and to Allah as well. It can risk their life. So this is really an alarming number for me as well. What is the risk stratified? So how do you assess? How can you say that you can have a fast, you can't have a fast? Of course, we have a duty as a Muslim, to be fair with our patients. This is a scoring system. We will go about a bit of number here, which is published by the Diabetes and Ramadan Guidelines in the South Asian, which tells us that if you are scoring between 0 to 2, 3, you're low risk, and then, moderate risk and high risk. And what are these scores based on? So I tell you, these scores are based on what sort of diabetes you have. What is the duration of diabetes? How many episodes of hospitalization you have? What sort of comorbidities you have? So this is a good guide where, you can sort of say my patient is a moderate risk, and you can even, just put it this in front of the patient that, look, this is the consensus, this is the guideline, this is the scoring system, and you are scoring 8. So, of course, you are a high risk. Now, one of the problems in Pakistan, I think, is the initiation of insulin. Usually, if patient is on multiple oral anti-diabetic agents, HbA1c is more than 8%, you should be, thinking of optimizing the treatment, increasing the treatment. But unfortunately, in Pakistan, the mean time to intensify with the insulin is 8 years, which means that most of the patients with type 2 diabetes, they have HbA1c of more than 9 before they start insulin. And of course, there's a lot of factors in this, but this is sort of a very bad number. We are going to look at that. And it takes 8 years. So you also have to tell your patient, most of the patients, they come to our clinic, they are on Mixtard 30 or Humulin or Insuget, 20 units, 10 units, sugars are not getting better, nobody is doing anything. Well, we need to tell the patient that giving an insulin or injecting an insulin will not sort out your blood glucose. You have to adjust the insulin dose as per blood sugar readings. We'll discuss about this in next few slides. This is the busy slide. I think all of us know here there's a consensus by the American Association of Clinical Endocrinology, European Society of Diabetes, Diabetes UK, NHS NICE guidelines. The paradigm is shift now. A few years ago, my senior colleagues must be remembering this, that we had only insulin and sulfonylurea and glucophage. There was nothing else. And, there wasn't much we could do. And as Dr. Imtiaz Saab has quite well said, that the UKPD data suggests that by improving the glycemic control, you can reduce the microvascular complications. But what about the macrovascular complications? We had nothing to protect the macrovascular complications. Well, your kidneys are going to fail in 20 years. So now the paradigm is shift. When the patient comes to you, you have to see whether my patient has heart disease. Is he got a high-risk heart disease? Is he got CKD? What's the GFR? It's not only the nephrologists now who are looking at GFR. You are the one who needs to look at the GFR. You are the, as I said, it's not just the numbers, it's not just the glucose. You have to see the patient as a whole. Because the time has changed, the world has changed, the kinetics and dynamics has changed. So you have to assess whether my patient is a high risk or has got kidney disease or heart failure. Because if your patient has one of these, you should be considering SGLT2 or GLP-1. Dr. Fawad is going to talk about GLP-1s in the next presentation. And I think it's a wonderful thing to talk about because it's the talk of the town, especially in Pakistan. We need to educate the clinicians as well because people are injecting it right and left without any sort of safety profile. Similarly, if your patient does not have any of these, as we see in the clinic, a lot of young guys, 30, 32, 28, 26. Well, I've seen patients with type 2 diabetes starting from 12 years of age. So this is another I would like to mention here and takes the opportunity that if the 12-year-old guy walks into your clinic, he may not have type 1 diabetes. He may have type 2 diabetes, so you need to assess it. You don't have to put the patient on insulin all the time. So weight management, of course, as I mentioned, Professor Fawad Saab is going to talk about, so I won't touch that more. This is almost the same slide as we discussed before. If your patient have high risk of cardiac disease or heart failure or kidney disease, then you should be considering some new agents because the data has said, as Professor Khurshid Saab has just mentioned about the EMPA-REG and role of empagliflozin, that you should be considering the new drugs which will benefit the patient from the heart point of view and kidney point of view. This is a bit of weight management. Of course, lots of GLP-1s are there, and it's going to be another world in the next 3-4 years. You will see hundreds of GLP in the market. There's a double agonist, there's a triple agonist, there is an amylin analog, there's a combination of semaglutide and amylin analog, which is showing 25% weight reduction in 36 weeks. So again, Fawad Saab will discuss this in more in detail. Now, we'll come to our own basic topic. You know, the topic today was actually about the insulin. So, Easeup. So, if your patient is failing on oral hypoglycemic agents, let's say...
I interrupt, you have 5 minutes more.
All right. So, I will be a bit fast. So you should consider injectable therapies, which could include GLP-1 and basal insulin. And I will not go in much detail, but I'll tell you the bottom line is, a lot of people ask this question, what sort of insulin dose we should start it. Usually, if you want to start a rough guide, you can start a patient with 10 units of insulin per day and you can titrate it up. That's the safe dose to start with in most of the patients. Now, today we are talking about the new insulin, which is a co-formulation of basal insulin and rapid-acting insulins. You don't have to give 2 insulins separate because they exist in the same co-formulation. IDegAsp, which is insulin degludec, and insulin aspart. I'm not sure many of us are, known to this degludec. In United Kingdom, we have separate degludec, which comes in the name of Tresiba, which is also available in basal insulin shape. But in Pakistan, we have this available in combination. Why you want to choose Easeup or a combination? I won't go in details of this because we're short of time. But I'll tell you the main things. Shoulder effect. What is shoulder effect? Shoulder effect refers to prolonged period of hypoglycemia following a meal with mixed insulin, because the window of hypoglycemia, it actually precedes the window of meal time. And it is a very common problem in when you're using human insulin and some analog mixed insulin. But this problem is solved with the Easeup, because Easeup, one is, of course, it is ultra long acting, less variability, mean half-life is more, and it does not cause stacking. Stacking is, when you're over-bolusing, over-correcting, sometimes the insulin cling together and you get more hypoglycemia risk. But this is not an issue. With the degludec initiation, you can start with 1 daily, twice daily, and then you can titrate it up. You can administer it with the oral hypoglycemic agents, without oral hypoglycemic agents. Of course, then you start it and then you have to titrate the dose, as I was mentioning earlier. Remember, it is ultra long acting, very long half-life, so you don't have to titrate every day. You have to titrate it every week. You can go up to 2 units as per the fasting blood glucose levels every week. Again, I would say which patient group will benefit from it. Of course, I think this is a very important slide. Patient who need to start insulin or switch from another basal insulin, when there's a risk of, when you think that my patient has a more risk of hypoglycemia, it is always better to switch in the newer insulins, which contains a different component of basal and the prandial component. Patients with irregular lifestyle, with the fasting plasma glucose or postprandial glucose, again, it is not recommended in pregnant women, but you can use in the pediatric age group as well. Ramzan, a lower rate of hypoglycemia with IDegAsp as compared to biasp insulin, low risk of nocturnal hypoglycememia, and you can have an advantage of dose reduction at 1 meal. You can give it with 1 meal, with 1 main meal. South Asian guidelines all suggest what you do in Ramadan, that you assess the patient. If the patient is on basal insulin, you reduce it by 15 to 30% if they want to fast. If they are on the twice daily insulin, then you can reduce the usual dose at iftar, and the sahur dose, you can reduce it by 50%. Similarly, what happens with the bolus insulin? You can reduce it or transfer the dose to the iftar time. And these are the key takeaways. It provides better glycemic control, less hypoglycemia. Thank you for your attention. Thank you.